Hello, it's Neil Durham reporting for GPonline.com at the new headquarters of the NHS Commissioning Board in central London. I'm here to speak to Professor Steve Field, who's the Deputy Medical Director of the NHS Commissioning Board. Why you decided to become a GP and when did you start practicing?
Well, the story about becoming a GP goes back to when I was at a school. I grew up in the Black Country, initially on a council estate in Woollerscote, Stourbridge, and I was the first one to go to university in our family. In fact, I was the first one to go past 13 or 14 at school. And as I grew up, I got more interested in inequalities and just the simple questions of, why did relatives die young? And it was mostly smoking-related illness. And I've been a very strident campaigner to try and stop smoking over the years. And so I went to medical school. Really, at the interview, I can remember they asked me a question, why do you want to become a doctor? And it was, I really want to do something about health and about communities. Having grown up initially in a deprived part of the West Midlands, I wanted to do my part, giving something back, to try and ensure that people who lived in areas that I grew up in would have the same opportunities of those who lived in Edgbaston or Surrey or Oldley Edge, whichever posh part of the country people understand. And so all of my jobs all the way through my career, at every interview, that's what I've talked about. And having been interviewed for this role leading on inequalities for the Commissioning Board recently, it was the same answer, because that's what drives me. And my role model as a schoolboy was my local GP, who was a very caring, sharing man who had the respect of a local community, and I wanted to be like him. And as I went through various jobs, people died and didn't apply for jobs, or I applied for jobs when I probably wasn't ready, but for some reason, by accident, usually I got jobs all the way through. And so I ended up in education, because I felt that was one way of helping lots of doctors look at education, inequalities. I stood for the College of GPs as chair, wanting to do something about inequalities. That's been the drive all the way through.
And did you ever think that you'd be writing the RCGP curriculum for training GPs at any point?
Well, I don't think you're born with that vision of a curriculum, are you? But I think what happened was I got more involved. I was a course organizer very early on, and the first stage was I was asked to get involved chairing a committee when I was very young between the BMA, Department of Health, and the college, because we were trying to transfer the money from income into education so that we could then develop educational programs. So the first stage was to try to get everybody to go through a 3-year program. Then I was involved in helping lead on summative assessment and became a college examiner as well. And then, really, it was about how do we get an assessment for all GPs so that GPs were of a high quality, rather than just when we brought in summative assessment, it was a fix, really. We wanted an assessment. Government only wanted to fail 6%. But really, we wanted one which was, if you were good, it wasn't to do with percentages. And so, in order to do that, you had to really understand what the training curricula in its broadest sense was about. So I had a 6-year program with a great team of people in Birmingham and around the country, where we looked at the best models around the world, and we wrote a comprehensive curriculum, which then also changed the examination of the college. So that's where we are at the moment. And I think from a legacy point of view, I'm very proud of having led that team to bring the curriculum into place.
And with an international field, tell us a little bit about your role with Harvard University and the teaching that you're doing there.
Yeah, I mean, one of the things that's really one of the highlights of the year is, it again goes from education. We decided when I was a postgraduate dean that we didn't have professional development for postgraduate deans. And so we worked with ASME and Harvard to set up a training course in England. And 12 years ago, they asked me to go and help with the faculty at Harvard. And so for the last 12 years, I've been helping lead the course, which is around innovation and leadership. And it's based on the philosophy of Clayton Christensen about disruptive innovation. And that is the core theory which drives a lot of what I'm looking and thinking about, how we disrupt the current model of provision of care so that we bring things closer to patients and really change what we're doing. And so that theory, I think, is very useful with healthcare. It's quite difficult applied to the English system, but it does mean, for example, that when we brought in stenting for heart disease, that took over from cabbages, the bypass operations, and you can predict how the workforce is going to change, but it's not widely used in this country. But so we run a leadership course using that as one of the key theories, but also trying to equip leaders from around the world who are clinicians to lead organisations. And one of the byproducts of it is it produces a network where clinical leaders from America, Australia, Holland, from Africa, from Korea, meet together and share experiences. And so I go there every year and help do things in between sometimes, and it's just really stimulating.
Talking about meeting together and sharing friendship, you've two daughters. You work as an inner-city Birmingham GP. And your wife, Lynn, was nurse director of the Birmingham Cancer Network.
Yeah.
How did you meet?
Well, we met actually when I was a GP in Worcester. I was a GP in Droitwich for 10 years, and she joined us in Droitwich as the nursing director, managing all of the, or leading all of the nurses in our locality, and that's where we got to know each other. And then shortly afterwards, the twins arrived. And the twins aren't going into medicine. That's the next question. They've decided they don't see much of me and I don't have much of a life. So actually, one of them is going, they're 18. Mm-hmm. One is going to study geography and the other history, which are my two loves outside medicine. So it's actually a success for me. It's a shame that one's not going to carry on in medicine, but I think they'll both be very happy.
And how have you found your work-life balance, having a family and numerous other roles in the NHS, which we will come on to?
Yeah, you need to define what the word balance means.
Have you found the balance? Or?
I don't quite understand. Well, I mean, from a work's point of view, I love everything I do, and I've been very privileged to be able to carry on seeing patients as well as having a variety of regional and then national roles. I think the girls would say that they don't see me much during the week, but I'm around all weekend. But when you look at other people, colleagues who are full-time in general practice, they get home 7:30 at night. When their children are growing up, they don't see much of them either. But so one of the regrets probably, I guess, is I probably haven't seen as much of them as I could have done in some of their formative years. So when I was leading the College of GPs, I lived in Princess Gate during the week. On the other hand, they have very fond memories of London and staying at Princess Gate and going to the theatre regularly and visiting museums. So it's swings and balances, really.
Now you've a new role. We're here at the NHS Commissioning Board's new headquarters. You're Deputy Medical Director. What does that role entail?
Well, again, it's another one of these jobs which was put to me as something where you could really change the world. So, and I believe that. So, all the way through, as I said before, there's a theme about me wanting to do something about health inequalities, and I know very much that the major determinants of health inequalities are the social determinants of health, but I do believe there are things we can do in leadership roles, not just in the social determinants, but trying to address the social justice problems of access to healthcare, ensuring that people have the same outcomes if they live in a deprived area compared with in a rich area. Moving care more towards the community, better palliative care for everyone. So what I have been given the fantastic opportunity to do is to lead the commissioning board in its attack on health inequalities, working very closely with friends and colleagues in Public Health England and Local Government Association, housing. And what I've been tasked with doing is to create a small team so that we can support CCGs and influence across all of the strategies to really make a difference. You know, the work I've been doing on inclusion, which is homelessness and gypsies, I mean, every meeting I go to, and it is every meeting I go to, homeless people say they've been turned away from GP surgeries. Yeah. And yet, last Thursday I was in Leeds in the York Street surgery that are providing fantastic care for homeless people. So I've seen brilliant care and I've seen poor care, brilliant access and poor access. Why shouldn't all people in this country have the same access? Because general practice can make a real big impact. So that's one thing we're going to be doing. But also care of gypsies and travellers, sex workers. There's things we can do about the poorest of the poor. The other committee I now chair, which has been led by Mike Richards and is starting to make a real impact, is about cancer outcomes for people in deprived communities. Yeah. We know that people with learning disabilities do far worse than the rest of the population. We know that people die younger in deprived areas. And yes, a fair bit of that will be about smoking, about alcohol. But actually, many of them don't come forward quickly enough to their GP.
And why don't they come forward quickly enough?
Well, I think part of it is they're not aware of really understanding the symptoms that might relate to cancer. Part of it, I think, is fear that they might be wasting the GP's time. Because we have this philosophy, I think. It's great in England that we worry about the NHS. It's like a spiritual thing, the NHS. But there is a real issue that people think it's free and therefore they might be wasting money or time. Yeah. Whereas that doesn't seem to happen in some other countries. So part of it is how do you encourage people to come forward? And we know that advertising, like in Doncaster, about the cough on around the town and on bus stops and things helps. But also receptionists being welcoming and not turning people away. GPs understanding different health beliefs of different populations, having access to translators for people who've come into the country who don't speak English. There's lots of things we can do, but I think the first thing we've got to do is recognise that everything's not wonderful in the garden. And once we recognise that things aren't brilliant, we can then move forward.
And what's the atmosphere like here in the commissioning board? Is it might be too top down, and that you might not allow people to develop things?
Well, I think actually it feels the opposite here. I mean, we believe genuinely that we're supporting CCGs to do their job, but we also have a role centrally with central contracts, and they include general practitioners' contracts, dentists, optometrists. So we do have some influence over contracts, but we're here to support local commissioners, particularly supporting local health and wellbeing boards. But the one thing I would say is we have an amazing team that we've hired for the medical directorate, and I'm in the middle of recruiting for health inequalities in one of the other directorates. But we've got great GP leadership. Martin McShane is quite exceptional. He's leading the domain which looks after long-term conditions, and it's great having other GPs around the table. Mike Buick, he's leading on revalidation. He's the GP and medical director for the north of England. It's just, there is a real sense that we're just starting to get more GPs engaged in national leadership positions, and they're lovely human beings, but also very bright and have a vision, and I think we'll take people with them.
Given that, a few weeks ago, Labour talked about the possibility of downgrading CCGs so they would become advisory bodies. Yeah. What do you think of that idea?
Well, it's difficult. So, honestly, I'm completely apolitical, and having led the Future Forum, I've also got involved with with the thinking of the current government, which was interesting. I think we need a time, as Labour have said, where we don't have much change. We consolidate where we are. Where I do think that they have a point, and this is one of the things I was trying to push through the Future Forum, is that we must get much more joint commissioning between health, social care, local government.
Yeah. And
that will come in different ways, at a different pace, but when it comes down to it, it's about human relationships. But I think at the moment, having just started to establish CCGs, they need time to develop and grow. But where I would agree is I do think they need to work hand in glove with local authorities. They need to share budgets where appropriate. And really, our attack on health inequalities has to be a joint attack between the politicians, Public Health England, Local Government Association, local government, and us. So they have a point about joining things together. That actually is what we wrote in the integration paper for the Future Forum.
And are you involved in the Bruce Keogh review of 24/7 care?
I'm not directly on the group, but it's coming from the medical directorate. So the answer by default is we will, have input to it, and therefore will be. This is something which Bruce has spoken about for many years now, and I would support him wholeheartedly. We need better care for our patients, 7 days a week. That doesn't mean doing the same thing on every day, but it will mean, I think, looking at how GPs work as well as hospitals work.
So would you like to see practices open longer, perhaps into weekends?
Well, I miss Saturday and Sunday working, and I think the new contract, in a way, did us a disservice, partly by restricting in the contract what people do. So there's a great reluctance to move beyond the contract now. But also, I think the way out of hours was handed over to PCTs was done very badly in many areas. It disincentivised people from working in cooperatives. We had a fantastic co-op in Birmingham called Badger, run by Faye Wilson. It was exemplary. And then the PCTs come in, mess with their contracts, reduce the value, and we end up with an inferior service. I led the ministerial review of the Urbani case in Cambridge. I saw how bad things can go, and that wasn't just a single doctor, it was how the PCT was run and managed those contracts as well. And I saw the wonderful work in Greenwich and Bexley and elsewhere around the country. And so I think we can do better.
And what would you like to see change from where we are now? Would you like to see co-ops return?
I think co-ops should be incentivised so that local GPs regain the ownership. But I also think we should be working much more closely with nursing and specialist colleagues. So I think we've moved on from where we were. And some of the work in the localities could be done much better working with nursing colleagues.
And when you say incentivise, presumably you mean a financial incentive?
Well, I think one of the issues we've got is the contract itself. Perhaps has run its course, and we probably need to work now looking at how care is provided in a slightly different way for out of hours. It would be different in a very rural area to in a city, the model of how you provide that care. But the way it's moved, I think there needs to be a review, and we need to involve the BMA in that as well. But it's more as well about how we work with emergency departments. What is an emergency department, an A&E, how GPs have got a particular role in particular localities. It might also involve how you use community hospitals. I mean, the world is very different now to it was 5 years ago. Now, if you've got a heart attack, you 999 straight into the heart unit. If you've got a stroke in the majority of the country, you go to a stroke centre. People are living now, whereas when I qualified in 1982, I became a GP in 1986, I can remember visiting a farm outside Droitwich and having to I had a big brick of a mobile phone, a carrying handle mobile phone, and I guided the ambulance in to the person who'd had a heart attack with my sort of mobile phone, immobile phone. Now GPs don't go out for chest pain. The world has moved on.
Yeah.
So I think we've got to think about, well, what does urgent care, what does out of hours care look like? How does it work with the 111 system? But how do you get local GP ownership? So I don't think it's going back to where we were. It's thinking about what needs to be provided now at the start of the 21st century.
So you're not ruling out financial incentives for GPs to get more involved with co-ops?
I think we need to use incentives in a way to improve the quality and safety of care. I wouldn't rule anything in or anything out, but just like how we would use tariff to look at the year of care model, or how you would incentivise care in various different ways for long-term conditions, then I think we should have a radical look at that.
And presumably you also think that GPs should be more active in managing patients in the community, so emergency admissions reduce.
Well, I don't think we should just be looking at GPs. I think really we should be looking at the primary care team. And in some areas it works very well as a team. And that team involves the patients. It involves the ambulance trusts. It involves nurses, community nurses, as well as GPs. And it might well include more outreach from hospitals for people with COPD using telehealth interventions. So what we've got to try and do is get to the point where we try and prevent people having to call for an emergency in the first place by being more proactive, and then putting clearer pathways in for patients, particularly those who might panic with COPD or other illnesses, which might be able to be given advice or monitored in different ways. So I think the whole thing about 7-day working is not just about hospitals, it's about primary care. And primary care, we would say we need better access to diagnostics as well. And we need better continuity of care for our practice list.
And do you think the quality premium opens GPs to criticism that they're rationing services for their own personal gain?
I think how it's been sold certainly does, but I think if we can work with the profession, with the quality premium, I think there are ways of incentivising behaviours. But we also need to learn from QOF, which I think, to be perfectly honest, has now become such a tick box system that it disincentivises holistic care in many cases. But it also has perverse incentives in that, or disincentives in that the thresholds also mean that some practices might not push harder for the more vulnerable, harder to reach groups. So I think we need to have an adult conversation about how we use incentives, how we work across geographical areas with federations of practices, how we look at how the community teams trained and grow. I think there's a great opportunity there.
Are you involved in looking at the NHS constitution and how that might change?
That's a sort of leading question, isn't it?
Well, I thought you were.
So my job until November was to lead the review of the constitution.
Right. Okay.
And we did a listening exercise at the Future Forum, which I led. We wrote a letter to the Secretary of State, and then because of the legal basis of the Constitution, I handed over to Norman Lamb, the Minister.
Right.
And Norman is now leading the formal consultation, and he published the responses to that on Friday of last week.
Right.
So I remain part of the Constitution Review Group, but I no longer chair it because legally it has to be a minister.
And what impact would a tougher constitution have on CCG rationing decisions?
Well, I don't think we're talking about a tougher constitution. In fact, one of the major problems we've had is people don't really know that it exists. So there are rights in there already based in law. So right to a NICE approved treatment, for example. But really you need to go back a step and talk about the values and the principles. You know, the values are what should shine through. So, and I, as you know, work very closely with homeless people. they have a right to be treated with respect and dignity, values in the Constitution. When they're ill, the value is about compassion. And the value which I love the most is around everyone counts. So every single human being in England counts. That means for patients, they should have the same right of access to approved treatments. They should have the same right to be treated with dignity and respect, whether in a hospital or in general practice. And most importantly, I think for staff, whether they're in general practice, dentistry or in hospitals, they also have a right to be treated with dignity and respect. Everyone counts, so they should have access to professional development. They should be treated appropriately and supported, because happy, inspired, motivated staff are more likely to look after their patients with compassion and dignity. And that's the philosophy that we've had for 60 plus years, but it's also the philosophy of successful organisations like John Lewis.
Are you, I think you're chairman of the National Inclusion Health Board, is that right? Is that a position you still hold?
The Labour government appointed me as chairman of the National Inclusion Health Board a few weeks before the election. We didn't think it would continue, but the incoming coalition government wanted us to continue. Our role is to try and champion the rights for health of vulnerable groups: prostitutes, gypsies, travellers, homeless and vulnerable migrants. And we're working closely with charities, with public health, with hospitals, with general practice to look at good models, to do all sorts of things to support that. So an example is I went to meet a group of GPs in Oxford, and I'd heard from the patients in Oxford that in some of the areas they were having difficulty registering, the patients were difficult registering with the practices. And we found out that what had happened was NHS fraud had produced a paper which gave instruction to practices, but basically meant that they were restricting patients. They had to have 2 bits of evidence, and I took that to the ministers, and we had it removed within a couple of weeks. So that's one thing we did practically to support GPs. Another would be to support the London Pathway, which is a GP-led intervention at University College London along the road from where we're sitting now, which is led by GPs and nurse practitioners, which helps people when they go into A&E, gives them a housing assessment, a social care assessment. It looks after them as a GP would holistically, and it's reduced the number of admissions and readmissions to hospital. It saves the trust £250,000 a year, but it also trains homeless people up so that they've got jobs. It's just absolutely wonderful. So things like that are what we're doing with that board, and we're building on that with the new role with Health Inequalities.
You mentioned your time at the NHS Future Forum as chairman. How do you now look back on that role?
It was the most wonderful experience, being asked by the Prime Minister to lead an independent group of people. Was just extraordinary. On the plus side, I met amazing people around the country, and I do believe we managed to significantly alter the NHS social care bill that became an act. I think we helped refocus Monitor so that we looked at competition as something which was useful but not the end in itself. It was a means to an end. I think we flagged up a lot of issues which will endure over the next few years, including collaboration and integration, making every contact counts for public health. We spoke to people in hostels, we spoke to academic professors, we spoke to industry, we spoke to lots of people around the country from all different views, and I think at the end the reports were sound. On the negative side, people seem to think that by leading this independent review, I was speaking on behalf of the government, and I know from my interactions that they valued the independence. But I learnt a lot, and from a life experience point of view, being able to chair meetings in the cabinet room at Downing Street with the Prime Minister sitting next to me was an amazing privilege. But also presenting our papers to the full UK cabinet was also quite an experience as well. And I think when people see through the very polarised view of competition and privatisation versus the NHS we've had for 60 odd years, I still think the NHS will shine and grow and prosper through all of this. But it's rather politically, polarised at the moment, and that's my great regret. But I guess it's a sort of offer you can't really turn down. And I do think we modified the Act to the point where, I became comfortable with where we are.
What do you think of Mr. Cameron's appointment of Professor Don Berwick to look at zero harm in the NHS?
Well, Don is he's just a wonderful, wonderful human being. He has a brain the size of a planet. He has wonderful values and communication skills, and I can remember being very emotionally charged on a number of occasions, listening to him at the RCGP annual conference, talking about his father, who was a doctor, and the values he had. And I've met him many, many times, and I've always been impressed by his drive for quality, for patient safety, for the patient at the centre of everything. And if he'd have carried on right at the top level in America, I think the Obama reforms would have really been wonderful. But unfortunately he didn't. I gather now he's standing for governor of Massachusetts as well. So there's no, we know he's coming over here in a few months' time, and I know quite a bit about how his work is going to be organised, and I think he's the ideal person to come in and advise us across the whole of a health system.
And when he spoke at the RCGP conference, you were chairman of the RCGP then. I think there were some tears in the audience. Why do you think he touches such a... What is it about him and what he says that brings out the emotions in GPs?
I think if you understand... we go into general practice to do good, regardless of what the Daily Mail might say. So we are there to help people, to support people, and to do that, you have to build a bond with human beings, and it's that emotional transference that happens between you and the patient, the GP and the patient. It's about how you're working with the patient holistically, physically, psychologically, socially, and there's often a spiritual dimension as well. And what Don has got a really wonderful way of talking is that he talks about patients and the interaction between patients and the doctors in that way. People who are into balance would really understand that. And what he talked about then, and I've spoken to him in many ways, even on a one-to-one he talks in a similar way. He understands that privilege, he said, of getting into the innermost secrets of that human being in front of you was the phrase that triggered the emotion. It's when you're talking with your patient, often you know more about that patient than the wife or their family, because they open up in quite a unique way. And that's the central thing of this. It's general practice at its core, and how we build up relationships, and how we build up relationships with the person in front of us and the family over time. In all of the reforms, in everything I'm doing for the commissioning board, we must not do anything to disrupt that interaction. What we must do is build on it and recognise that GPs will work more with teams with nurses, but and they will work across different populations. But a GP relating to somebody, as I do in my practice, who are homeless, who've not worked for years and years, and those who are professors of great institutions in Birmingham, we would treat everyone with the same compassion and dignity. And Don Berwick brings that across in a unique way, which I just think is wonderful.
Talking about professors, Claire Gerarda recently became a professor. She
did.
Was your successor. She came after you at the RCGP. What do you think of how she's chaired the RCGP, and would you have done anything differently?
Well, I was chair, so I stand on how I chaired the college. Claire was my deputy, and we remain very, very good friends. And people have their own individual styles. And what I would say from Claire's point of view is that she's one of the most value-driven people I know, and she really cares about human beings. And her track record of working with deprived communities, with people with drug and substance misuse, and more recently working with sick doctors, is just absolutely wonderful.
And finally, I thought we should talk a little bit about the Francis report, which came out last week. How do you think the NHS needs to change after the publication of the Francis report?
Well, I think probably quite uniquely amongst doctors, I've read it. 3 volumes, 290
pages or something.
Yeah, I had 3 very long train journeys and then time in hotels, and I've read it because I felt I wanted to really understand it. I live in the West Midlands. I understand where the people in Stafford are coming from. I met with Julie and Ken and others as part of the Future Forum. I went to speak with Cure the NHS, and I had access to a number of their documents, and you'll find in the Future Forum reports words that they've used, and I do really understand where they're coming from. I also, when I stood down from the college, went and did some work with some of the GPs there when they were talking about early CCGs, I think there's all sorts of lessons we can learn, and I think what Francis talks about in his first 12 recommendations are around the NHS constitution. Something happened to the individuals and the systems, and it went badly wrong. And I think if you look back at the values of the constitution, if you follow those values, respect, dignity, compassion, doing the best for everyone counts. If you live those values, you wouldn't have a Stafford. So you've got to work out, well, what happened to create the environment that went wrong over many, many years. And the first thing you've got to start off back on is how we get those values back. And then you look at the systems and you make sure that the systems don't create environments where things happen. And so I think for the commissioning board, the single most important thing we will have to do is promote the values of the Constitution, select staff for values, train for skills, introduce the values as part of the appraisal process so that everybody understands what's expected of them. But I think there are also lessons around whistleblowing, which we put something into the Constitution last year but needs to be strengthened. I personally promoted the legal duty of candour. I thought that was something which would be very sensible. But like a number of things in the Future Forum, I might be in favour of one thing, but what we heard wasn't enough support for it, so it didn't go in my letter as a firm recommendation, but that's what I personally believed. But when it comes down to it, this is about individual actions of individual doctors, nurses, managers, living out the values of the Constitution. And if we live those values out in our management, how we're writing protocols, how we're looking at management arrangements, how CQC works, we need to make sure that endures. So we could talk for hours because there are hours of material, but for me it's the values part of it which is really, really important.
There have been some calls for NHS Chief Executive Sir David Nicholson to either resign or be sacked. What do you think of those?
People will feel very, very angry and will call for human sacrifices. I would agree personally with Francis that what we need to do is read and learn the lessons and unite and move forward on that. I know David particularly believes in the Constitution. He's been the strongest advocate that I know for the values of the Constitution over the past 5 or 6 years. And at a time when the commissioning board is just about to launch, at a time when we're recruiting, I think people calling for David's head need to reflect that we need to get the commissioning board up and running and move forward. We've only got 6 weeks to go, and I think there are bigger lessons to learn from the Francis report, which will take many, many months to understand and to come to terms with.
So you think he should stay?
Exactly what I've said, really, that from a commissioning board's point of view, to lose your leader at this time, when we're setting up, ready to roll with the commissioning board, we're still in the middle of recruitment. One of the big lessons, I think, from the Francis report was around the mergers of strategic health authorities, the legacy handover from 1 to 3, and things dropping through the cracks. And I think what one should do is reflect on whether this is the appropriate time to lose a leader, even though it would be a very, very easy thing to call for and to deliver externally. The system is fragile. All transitions are fragile. Patients' lives are very, very important, and we need to make sure that this transition is as smooth as possible whilst we learn the lessons of Francis and make sure it doesn't happen again. And I think part of that is Bruce Keogh's review of the so-called failing hospitals, those with the whose data might indicate problems. I think Bruce's review is very, very important.